Good evening, everyone. Myself, Dr. Nasrin, Assistant Professor, Department of Anesthesiology, SLIMS. Today, we'll be talking about hemostasis. Hemostasis is defined as the process of blood clotting and then the subsequent dissolution of the clot for repair of the injured tissues. There are two hemostasis, primary hemostasis and secondary hemostasis. Primary hemostasis includes the formation of a platelet plug, that is, which include the platelet adhesion, platelet activation, platelet aggregation, and secondary hemostasis, which activates the coagulation cascade. Coming to primary hemostasis, following a blood vessel injury, the neural mechanism will get activated and will result in the blood vessel constriction, resulting in reduced blood flow that will lead to stable hemostatic plug. Meanwhile, there will be a contact or tissue factor activation, leading to the activation of coagulation cascade, fibrin formation, and subsequently the stable hemostatic plug. And both of this will lead to the platelet aggregation. All of this will result in the primary hemostatic plug. And the next step will be the platelet adhesion. That is, for disruption of this endothelium. Disruption of this endothelium exposes the subendothelial von Willebrand factor, and this von Willebrand factor and collagen. This von Willebrand factor will bridge the gap with bridges GP1B on the platelet with subendothelial collagen. Then there will be conformational change in the GP2B3A, which leads to aggregation of platelets and binding of platelet to fibrin. And thromboxane A2 will get released. That also will lead to aggregation of platelets. This diagram shows that is the following injury, there will be the release of 1 milligram factor and collagen that will lead to platelet adhesion. The first step is platelet adhesion. Subsequently, there will be change in the shape of the platelets and there will be release of the granules such as adenosine diphosphate and thromboxane A2. And the fourth step is recruitment. There will be recruitment of multiple platelets and that will lead to aggregation and finally a hemostatic plug. And any deficiency in this 1 milligram factor will lead to von Willebrand disease. And deficiency of GP1B results in Bernard-Solier syndrome. And deficiency of GP2B3A complex will result in Glanzmann's thrombasthenia. And we have seen what is primary hemostasis. Now we will see secondary hemostasis. That is the activation of coagulation cascade. There will be series of amplifying enzymatic reactions leading to deposition of insoluble fibrin clot that will result in the activation of intrinsic and extrinsic pathway. Intrinsic coagulation factors are synthesized hepatically. That's they'll be synthesized in the liver and they circulate as the inactivated proteins known as zymogens. This membrane-bound activation complexes chuckers on the phospholipid membranes of the platelets. All of this consists of the activated factor, that is the enzyme, and a substrate will be needed, that is the inactivated precursor, and accelerated will be there, and that fourth is calcium. This is the extrinsic, this shows the extrinsic and intrinsic pathway. Extrinsic pathway, that is initiating step in the plasma mediated hemostasis. This leads to exposure of the blood plasma to the tissue factor, which is released by the subendothelial cells. This results in activation of more and more factor 7A, leads to generation of thrombin. An intrinsic pathway is the amplification system to propagate the thrombin generation initiated by extrinsic pathway. Results in activated factor 11 by thrombin produced by extrinsic pathway and activated factor 12 by foreign surfaces like glasses, and more thrombin is generated. Finally, there is final step is the generation of thrombin. What are the clotting factors? There are 13 clotting factors named as factor 1 is fibrinogen, factor 2 is prothrombin, factor 3 is tissue thromboplastin, factor 4 is calcium ions, factor 5 is labile factor, factor 7 is stable factor, factor 8 is anti-hemophilic factor. Christmas factor plasma thromboplastin component is factor 9, Stewart power factor is factor 10, plasma thromboplastin antecedent is factor 11, and Hegman factor is 12, and fibrin stabilizing factor is factor 13. This diagram shows the intrinsic and extrinsic pathway. Intrinsic pathway, negatively charged surfaces such as glass beads, when it is comes in contact with the blood surface area, there will be activation of factor 12 to activated factor 12. That activated factor 12 will convert factor 11 to activated factor 11, and activated factor 11 will convert 9 to activated factor 9A. This, in presence of factor 8, will convert factor 10 to activated factor 10. That is from extrinsic part, that is tissue factor. In presence of factor 7, will convert factor 7A, or factor activated factor 7A, and activated factor 9A in presence of activated factor 8 will convert factor 10 into factor 10A. That will convert prothrombin to thrombin. Then thrombin, in presence of thrombin, fibrinogen will get converted into fibrin clot. This is the same diagram showing intrinsic and extrinsic pathway. Here, factor 10, calcium. This diagram shows the importance of this enzyme, such as callicarine, phospholipid, high molecular weight kininogen, and calcium. All of this is needed for the conversion of inactivated factors to activated factors. Prothrombin will convert into thrombin. More and more thrombin will be formed. Thrombin in presence of fibrinogen will convert into fibrin monomer. Fibrin monomer will further form fibrin polymer, and finally there will be formation of cross-linked fibrin polymer. Now we have seen what is coagulation. We have to see what is anticoagulation mechanism. For following blood and flowing, what are the anticoagulation mechanisms? Flowing blood and hemodilution, fibrinolytic systems, tissue factor pathway inhibitors, protein C system, and serine protease inhibitor. Tissue factor pathway inhibitor inhibits factor 7A. What one protein C system inhibits thrombin, factor 5A, and factor 7A. Serine protease inhibitor inhibits antithrombin 3, and this results in the binding and inhibition of thrombin. These are the anticoagulation mechanisms. And fibrinolytic system. Vascular endothelium produces tissue plasminogen activator or urokinase. Plasminogen will convert into plasmin in presence of tissue plasminogen activator, and this degrades factor 5A, factor 7A, and it also degrades fibrin. And now we will see what are the tests of coagulation. Um, Tests of coagulation. There are various steps of coagulation. Tests of coagulation. This includes activated partial thromboplastin time, prothrombin time, international normalized ratio, thrombin time, bleeding time, whole blood clotting time, platelet count. This now will come to what we'll see individual things. This activated partial thromboplastin time. This activated partial thromboplastin time measures the efficiency or efficacy of intrinsic and common pathways. It will measure both. This is the test of coagulation of for both intrinsic and common pathways. It is used to monitor treatment effects with heparin. Those people who are receiving heparin, low molecular weight heparin, all those people we have to give them this test at activated partial thromboplastin time. Normal APTT is 25 to 39 seconds. And where will we see a prolonged APTT? The prolonged APTT is seen in patients who are receiving heparin, and patients on direct thrombin inhibitors, and in patients who are having deficiency or inhibitors for factors in intrinsic or common pathway. These factors, that is factor 2, factor 5, 8, 9, 10, 11, and 12. And lupus anticoagulant, vitamin K deficiency, and severe liver disease. What is prothrombin time? This is the time that is taken for plasma to clot after addition of a tissue factor. This tissue factor is obtained from animal, and will add calcium to the citrated blood. So adding addition of tissue factor, calcium to the citrated blood we will add, and the time taken for this plasma to clot is defined as prothrombin time. It measures the quality of extrinsic pathway and common pathway. This is also extrinsic pathway and common pathway. This APTT measures intrinsic and common pathway, and PT measures extrinsic and common pathway. The normal prothrombin time is 12 to 15 seconds. This is prothrombin time is prolonged in deficiency of factors 2, 5, 7, 9, 10 or fibrinogen, and patient with liver diseases, vitamin K deficiencies, and patients who are taking oral anticoagulants such as coffee. All of these patients, the prothrombin time will be prolonged. And coming to international normalized ratio, each manufacturer gives an international sensitivity index, that is ISI, for any tissue factor limit. The ISI value indicates how the particular batch of tissue factor compares to an internationally standardized sample. ISI is usually between 1.0 and 1.4. INR is the ratio of a patient's prothrombin time to normal, that is control sample, raised to the power of the ISI value for that control sample used. So INR is equal to PT of the test, PT divided by PT normal, just raised to the power of ISI, that is International Sensitivity Index. So normal INR is between 0.9 to 1.4. Therapeutic value ranges between 2 to 4. Patients on warfarin therapy, for them, 2 to 3 is acceptable. Higher values may be accepted in situations like patient with mechanical heart valves, those who have undergone valve replacement therapies. INR greater than 1 indicates elevated clotting time. Less than 0.5 means they'll have a higher chances of clotting. More than 5 is unacceptable. INR of more than 5, this patient will have high risk of bleeding. And then coming to thrombin time, this is a time taken for the clot formation after addition of thrombin to saturated blood. This thrombin time is prolonged in patients who are receiving heparin, direct thrombin inhibitors, paraproteins, and fibrinogen deficiency. Then bleeding time using IV method, a blood pressure cuff is placed on the upper arm and is inflated to 40 mm of mercury. And lancet is used to make a stab wound on the underside of the forearm. The time from when the stab wound is made until all bleeding has stopped is measured. Every 30 seconds, a filter paper or paper towel is used to draw off the blood. So normally it is 2 to 5 minutes. Coming to whole blood clotting time, which is a time interval between the entry of a blood into glass capillary tube and formation of fibrin threads. And the what method uses right capillary gas tube method. Normal time is 3 to 6 minutes. It is prolonged in patients with severe deficiency of any coagulation problems. Clot should retract in 30 to 60 minutes. Weak friable clot means hyperfibrinogenemia, and early dissolution occurs in enhanced fibrinolysis. Platelet count. This is a norm. What is normal platelet count? Between 1.5 to 4.5 lakhs. If count is less than 20 minutes, there is a chance of spontaneous bleeding, and it is considered to be a life-threatening risk. Increased count is known as thrombocytosis, which is seen in myeloproliferative disorders. What are the points of care of point of care measures of coagulation? Uh, these are point of care means where the patient is there. From there only we will take the sample, and then and there we will give the result. That is known as point of care measures. There are functional measures of coagulation, monitoring of heparin concentration, viscoelastic measures of coagulation, platelet function analyzer. Functional measures of coagulation includes activated clotting time, that is ACT, heparin management time, that is HMT, prothrombin time, that is PT, and activated partial thromboplastin time, that is APTT. Monitoring of heparin concentration using protamine titration, ion selective electrodes, other things, viscoelastic measures of coagulation. These are the newer measures of coagulation, that includes thromboelastography, rotum, and sonoclot, and platelet functional analyzer based on optical aggregometry based on the flow cytometry using fluorescent labeled antibodies. Heparin concentration measurements, that is protamine titration. Heparin concentration measurement we will see first, that is protamine titration. This is used to determine the heparin concentration in the perioperative setting. Increasing concentrations of protamine are added to a sample of heparin containing blood. in the heparin containing blood, we will add increasing concentrations of protamine. The time taken for the clot formation decreases. After a point, protamine concentration exceeds heparin and there will be delay in the clot formation. The advantages of this is it has a sensitivity for low heparin concentrations, insensitivity to hypothermia. It is not affected by apoprotein. A protein. Limitation is that there is a failure to directly access anticoagulation effect. And functional measures of coagulation, that is activated clotting time. Activated clotting time, that is used when heparin concentration is high, like those patients who are undergoing cardiac surgeries, valve replacements, who are at cardiopulmonary bypass. In this, there will be mixing of whole blood along with the contact activating substances, which is having a large surface area. Is that is this case phthalate or iodine. This speed the activation results in contact activation, which is occurs by classical intrinsic pathway. This ACT is influenced by hypothermia, thrombocytopenia, and in presence of contact activator inhibitors such as protein and pre-existing coagulation deficiency. In cardiac surgery, ACT is determined when it is determined before administration of heparin and 3 to 5 minutes after administration and at every 30 minutes interval. So for patients who are undergoing cardiac surgeries, the target ACT value should be more than 350 to 400 seconds. So, coming to the next measures of coagulation, that is viscoelastic measures of coagulation. This indicates the ability to measure in whole blood the entire spectrum of clot formation, that is from early fibrin stand formation to clot retraction and fibrinolysis. What have we seen? That includes TEG, ROTAM, and sonoclot. Now we'll see and discuss detail about TEG, that is thromboelastography. This thromboelastography analyzes each phase of clotting process, that is from platelet plug, clotting factors, and fibrin. How it is done? It is done by using a citrated bed. A citrated bed is introduced into the sample cup of TEG machine. A cup oscillates. This is how it is done. A cup oscillates around a submerged torsion pin, which is connected to the computer. As the coagulation occurs, the pin adheres to the clot and begins to move. This pin moves along with it. So this magnitude of the pin motion is directly proportional to the strength of the clot. This pin motion is displayed graphically by the computer. The torsion pin remains motionless until clotting begins. Amplitude increases as the clot grows and decreases as the fibrinolysis begins. This is the TEG machine. Here, this is the principle. Here, this is a citrated blood. 0.36 ml of whole blood is added. In that, a pin is immersed. Along with this pin is connected to the torsion wire, and this rotates at a speed of this angle 40 to 45 degrees. It just rotates when the clot formation occurs. This pin, which is immersed in this citrated blood, will start to move. Along with that, the torsion wire moves, and this torsion wire is connected to the computer. This computer will show this pattern. That is, this graph will be seen. This graph is analyzed, and 5 parameters are assessed. That is R time, that is reaction time, K time, alpha angle, and maximum amplitude. This is R time. From the time of no clot formation to the beginning of clot formation. This is the K angle, and this indicates the maximum amplitude of the clot formation. And after 30 minutes of clot formation, there will be starting of lysis, that is noted by L by 30, lysis 30, and after that there will be fibrinolysis. And these are the patterns such as seen in TEG. This is the normal TEG. And in anticoagulation or factor in any factor deficiency, initially there will not be any clot formation. Later on, there will be clot formation. In cases with hypofibrinogenemia, there will be very thin pattern of this MA and LY30 will be very thin. Hypofibrinolysis, initially there will be increased fibrinolysis. That is, the MA time will be more. Maximum amplitude will be more initially. Later on, the LY30 will be decreased. In hypercoagulable states, everything will be more. Then, coming to approaches to bleeding disorders. Well, what are the bleeding disorders? It can be a platelet disorder, or a coagulation disorders, or DIC. DIC is disseminated intravascular coagulation. Platelet disorders. Patients with platelet disorders will present with petechiae, ecchymosis, menorrhagia, and GA bleeding. And coagulation disorder, patient with coagulation disorder presents with ecchymosis, late wound bleeding, and extensive hemorrhage, like joint space hemorrhage, and following even immunization there will be severe bleeding. That all the symptoms are and these are the symptoms of coagulation disorders. DIC, that is there will be bleeding from multiple sites in any ill patient. Laboratory evaluation of coagulation pathways. As have we have already seen, partial thromboplastin time, surface activating agent will be used. That is kaolin, phospholipid calcium will activate the intrinsic pathway. Thromboplastin, tissue factor, phospholipid calcium will that will indicate the prothrombin time. So extrinsic pathway, prothrombin time, partial thromboplastin time, intrinsic pathway. For common pathway, we use thrombin time. Clinical aspects of bleeding. Patients with the platelet factor disorders and coagulation disorders will present with different signs and symptoms. For example, if there is a bleeding in the skin, mucosal membranes such as epistaxis, gum bleeding, vaginal bleeding, GIT. These are the sites of bleeding in patient with platelet factor disorders. If in a patient with coagulation disorder, there will be bleeding in the deeper tissues, deeper soft tissues like this, large bone effusions, hemorrhagic effusions will be seen in coagulation disorders. And petechiae in patients with platelet factor disorders will be very small petechiae will be seen. In patients, there will not be any petechiae in coagulation disorders. Ecchymosis usually will be small and superficial in platelet factor disorders. In patients with coagulation disorders, there will be large and deep ecchymosis. Hematosis, muscle bleeding is common in coagulation disorders, whereas it is extremely rare in patients with platelet factor disorders. Bleeding after cuts, scratches will be seen in platelet factor disorders. Patients with platelet factor disorders will have immediate bleeding after surgery or trauma, and it will be usually be mild. Whereas in patient with coagulation disorders, this bleeding after surgery will be delayed. Usually after 1 to 2 days, it will be seen. There is a spontaneous mucous membrane bleedings in platelet factor disorders, and only with trauma there will be bleeding in coagulation disorders. So, bleeding disorders are classified into inherited bleeding disorders and acquired bleeding disorders. Like inherited bleeding disorders include von Willebrand disease and hemophilias, whereas some acquired bleeding disorders include liver DIC, that is disseminated intravascular coagulation, and liver and renal patients with liver and renal dysfunction, and patients who are receiving anticoagulants. This all comes under acquired bleeding disorders. Von Willebrand disease. This is characterized by quantitative or qualitative deficiency of von Willebrand factors. It is most common. It is the most common inherited bleeding disorder. There will be deficiency of von Willebrand factor, and we use bleeding time, and there will be prolonged bleeding time and prolonged APTT. In mild cases, can be managed with desmopressin. In severe cases, cryoprecipitate factor 8 and von Willebrand concentrates are used. And hemophilia. This is a bleeding disorder due to deficiency of clotting factor 8, 9, and 11A. There are three types of hemophilia. There is hemophilia A, hemophilia B, and hemophilia C. This is the most common. That is A. Most of 85% of the patients will have hemophilia A. There will be deficiency of factor 8. This is X-linked recessive. A and B both are X-linked recessive, whereas C is autosomal recessive. This is X-linked recessive. This is autosomal recessive. Hemophilia C is very rare. Only 1% of the patients where there will be deficiency of factor 11. And hemophilia B is also known as Christmas disease. There will be deficiency of factor 9, and it is seen in 14 percentage of the patients. About 30% of the patients have no family history of this disease. So there will be these patients, it is not in it. This is like a new somatic mutation. Clinical features, this correlate with the percentage activity of factor 8, and then that all depends on the severity of the disease. severe form of disease and mild form of disease. In severe form of disease, less than 1% activity, spontaneous bleeding into the joints, muscles, vital organs like CNS, and there will be retroperitoneal bleeding. In mild disease, it usually goes undiagnosed until the patients have major hemodynamic stress like trauma or surgery. We investigations in patient with hemophilia, there will be prolonged APTT, but there will be normal BT and bleeding time and prothrombin time. It usually is managed with factor 8 because since there is a deficiency of factor 8 replacement, fresh frozen plasma, cryoprecipitate, IV desmopressin, or Nova 7, that is recombinant factor 7A. And FFP for 0.5 to 0.9 unit of clotting activity per ml should be cryoprecipitate. 1 unit has 80 Indonesian unit of factor 8. So desmopressin acts by releasing the preformed factor 8 and 1 milligram factor within 30 to 60 minutes. Nova 7, how it acts, it binds to the liver factor, which is exposed at the site of injury, generates thrombin by bypassing factor 8. Expression of tissue factor is limited to the site of injury. So hemostasis by recombinant factors, activated factor 7A is limited to the site. That is so, how much it should be given? 90 to 120 microgram per kilogram of Nova 7 should be given, and it should be repeated every 2 to 3 hours. How is factor 8 given? This factor 8, we have a formula to calculate how much of factor 8 should be given. Weight into desired percentage increase into 0.5. Uh, this factor 8 can be given if the can be given as intramuscular injections if factor 8 activity is more than 30%. Regional anesthesia is contraindicated in patients with hemophilia because of the risk of hematoma. Uh, So general anesthesia is contraindicated because of the risk of hematoma. General patient with, if they are giving general anesthesia, care has to be taken while applying pressure during bag and mask. Laryngoscopy should be done only after factor 7 correction, and well lubricated smaller size endotracheal tube should be used. Nasal intubation should be avoided. And intraoperative transfusion, whole blood is preferred over packed red blood cell concentrate. In postoperative period, NSAIDs should be avoided. In place of NSAIDs, opioid analgesics should be preferred. Factor 8 should be supplemented 5 to 8 days postoperatively and 2 to 4 weeks postoperatively. Coming to disseminated intravascular coagulation, this is a diffuse bleeding disorder associated with consumption of coagulation factors and platelets during widespread microvascular thrombotic activity. It is also known as consumption coagulopathy. Causes of this is following trauma, amniotic fluid embolism, malignancy, sepsis, and incompatible blood transfusion. This is induced by the cytokine pathway or by release of procoagulant substances. Um, this is there is balance that is breakdown of clots and formation of clots. This balance is lost in patients with BIC. There will be widespread clotting and the release of depletes the clotting part. There will be continuous bleeding. One part there will be continuously bleeding. Other part there will not be formation of any anticoagulation mechanism. So thrombosis plus bleeding. This widespread clot formation results in ischemia, necrosis of and organ damage and depletion of platelets and clotting factors, and fibrin degradable products is in circulation. This will interfere in clot formation. Finally, results in bleeding. There is a scoring algorithm used for diagnosis of DAC. So platelet count, if it is more than 1 lakh, it is given a score of 0. If it is less than 1 lakh per deciliter, it is given a score of 1. If it is less than 50,000 per deciliter, it is given a score of 2. Prothrombin time, less than 3 seconds is 0, 3 to 6 seconds score of 1, more than 6 seconds the score of 2. Fibrin degradation products, no increase means 1. Moderate increase to strong increases. The fibrinogen level, if it is more than 1 gram per liter is 0, less than 1 gram per liter is 1. Platelet count, prothrombin time, fibrin degradation forward, fibrinogen level, all of this is done. If score is more than 5, it is consistent with over DIC. If it is less than 5, not likely to be DIC. We can repeat this test after 1 to 2 days to confirm the diagnosis of DIC. Investigations to be done includes low platelets, low fibrinogen, and prolong patient platelets, fibrinogen, PT, APTT, and D dimer. So platelet will be low, fibrinogen will be low, APT and APTT will be prolonged, and D dimer will be elevated. Um, treatment treatment mainly focuses on the underlying cause. Supporting the vital organs like support ventilatory support, transfusions, correction of acidosis, dehydration, then prevention of renal failure, transfusion with FFP and cryoprecipitate. So mainly treatment, one part is focusing on the treating on underlying cause and supportive treatment. Then we have seen what is hemostasis, what are the tests of coagulation, and we'll see what is procoagulants. These are in perioperative setting following trauma surgery. Procoagulants are used to treat bleeding. They include antifibrinolytic agents, protamine, desmopressin, fibrinogen, topical agents, recombinant coagulation factors, that activated 7A, factor 8, and PCC, that is prothrombin complex concentrates. Antifibrinolytic agents. This includes lysine analogs such as epsilon aminocaproic acid and tranexamic acid and upprotein, that is serine protease inhibitors. That is epsilon aminocaproic acid and tranexamic acid. They act by competitively inhibiting the activation of plasminogen to plasmin. So fibrin degrades fibrin clots, fibrinogen, and other plasma proteins. Tranexamic acid at higher doses also inhibits plasma. It is how it is given. It is given at a dose of 15 milligram per kilogram. That is total of 1 gram given slowly as a IV infusion. Rapid injection may result in hypotension, bradycardia, and cardiac arrhythmias. Tranexamic acid blocks GABA receptors in the frontal cortex, and there is a hence in high doses can result in seizures. Protamine. This is a polypeptide containing arginine residues. It's only available agent to reverse unfractionized heparin. It acts by acid-base interaction, inhibits the platelets and serine proteases involved in coagulation. Usually, adverse reaction occurs. Usually, patients who are sensitized from exposure to NPH. Those people in like diabetic patient receiving NPH insulin, neutral protamine hack block insulin, which contains insulin and protamine. They include anaphylaxis, acute pulmonary vasoconstriction, right ventricular failure, and hypotension. Coming to desmopressin, it is a V2 analog of arginine vasopressin. It releases the ultra-large 1 milligram factor multimers from endothelial cells. It also releases vasoactive mediators, and it should be so that it should be given very slowly. Dose is 0.3 milligram per kilogram IV, given over 15 to 30 minutes. Fibrinogen. It is the plasma glycoprotein which is synthesized in the liver, which has a T half of 3.7 days. Normal levels are 200 to 400 milligram per deciliter. In the trimester of pregnancy, more than 400 milligrams. It's a substrate for thrombin, factor 8 and plasmin. During major hemorrhages, there's a blood loss and hemodilution, decreased plasma fibrinogen levels. Low fibrinogen is under recognized cause for excessive bleeding. So fibrinogen concentrates is often drug for treatment of congenital afibrinogenemia. These antifibrinolytic agents are given as intravenous injections. So now we'll come to see what are the topical hemostatic agents. These topical hemostatic agents are applied at the site of wherever there is a bleeding, at the site of bleeding, the site wherever there is a vascular injury to promote hemostasis. There is gelatin sponges, that is gel foam. And this gelatin increases the contact activation, helps to create a clot. And surgical or oxy cell. It is oxidized regenerated cellulose which works like a gel form, just like gelatin sponges. And bioglue, it has a glutaraldehyde. This glutaraldehyde will which cross links the proteins to fix wherever it is applied. So these are the topical hemostatic agents. It is applied at the site of injury. So let us summarize the class. What all we have seen? We just initially saw what is hemostasis. That is extrinsic and intrinsic pathway. We have seen what are the factors clotting. Right? We have seen what is primary hemostasis. We have seen what is secondary hemostasis. What is extrinsic and intrinsic pathway. What are the clotting factors? Then we have concluded what is hemostasis, and then coagulation we have seen, and we come to see what are the anticoagulation mechanism and what are the tests to find for coagulation, like activated partial thromboplastin time, prothrombin time, INR, thrombin time, bleeding time, and whole blood clotting time, platelet count. We and then we saw what was the point of care measures of coagulation. Functional measures of coagulation, monitoring of heparin concentration, viscoelastic measures of coagulation, platelet function analyzers. Each one we saw separately, activated clotting time, and the newer methods, that is viscoelastic measures. In that, we saw only TEG. Other things, rotem and the sonoclot also will function in the same manner, but we have not seen TEG. We have seen. Then and then we have seen what are the bleeding disorders, how to approach bleeding disorders, what are the clinical features, what are the investigations to be done, and what is the treatment of all the bleeding disorders. And that comes to, and finally we saw what are procoagulants, and that brings to the end of the session. Mhm. Hope all of you understood. Any questions? If anyone is having any doubt, they can ask. Okay. Okay. It seems there are no more questions. Okay. Thank you.